Hello, my name is Matthew Dito, and this is my oral presentation for my final capstone paper, a literature review of genomics and public health. In 2003, the Human Genome Project completed the first full sequencing of human DNA. Since then, medicine has sought to use this data to improve health for individuals and populations. Advances in genetic technology has led to new tools and frameworks that explore genetic disease to develop interventions. Whole genome sequencing and whole exome sequencing are two new powerful tools that can identify human gene variations. Whole exome sequencing analyzes the sequences of genes that code for protein and their products, as well as the functions related to them. Whole genome sequencing analyzes the full complement of genetic data for these same purposes. Researchers and doctors are seeking ways to integrate and validate genomic data. Public health provides an ideal lens to evaluate genomic tools, assess new interventions, and ensure that guidelines promote positive health outcomes. The March of Dimes reported in 2013 that congenital defects account for 20% of neonatal deaths and are responsible for aggregate hospital costs of over $4 trillion. This provides a natural target for public health professionals to identify members of the population that will benefit from early intervention and lead to reduced overall costs. The field of public health genomics is focused on the responsible and effective application of genomic data and tools to improve population health. My intention is to show that public health lessons from the national implementation of neonatal screening for phenylketonuria provides a natural roadmap to understanding where genomic data fits into public health. Success in neonatal screening and new screens of colorectal cancer tumors or breast cancer tumors for gene variations has provided evidence that public health has an important role to play. The CDC identifies the essential services of public health. Services fall into three broad categories of assessment, policy development, and assurance. Evidence has been generated that shows public health principles applied to genomic data can assist with the development of chronic disease management programs, application of social and behavioral principles to implement new procedures and guidelines, and assure patients and communities through education, support, and referral services. As phenylketonuria provides a natural model for screening programs, I would like to talk more about it. Phenylketonuria was identified in the early 20th century as a cause of severe cognitive deficits. A congenital absence of the enzyme phenylalanine hydroxylase leads to a buildup of phenylalanine and its metabolites. In the 1950s, evidence demonstrated that a diet low in phenylalanine was protective. However, this therapy had to be initiated immediately after birth, before the metabolites could accumulate. In 1963, a cheap and easy assay was developed that could identify and diagnose PKU. This led to a surge of optimism that other congenital forms of cognitive deficits could be readily diagnosed and treated, maybe with something as easy as diet. This led to national PKU screening guidelines, and today many countries screen all newborns for PKU. The success of the PKU screening program demonstrated the utility of screening newborns and became a model for programs around the world. Since then, the recommended screening program has grown to include up to 50 disorders with another 80 as secondary targets. In 2015, severe combined immunodeficiency was added to this list. After the successful implementation of mandated newborn screening in the 1950s, the WHO tasked Wilson and Youngner with developing screening guidelines. Their seminal book, published in 1968, provided a standard with which to judge screening programs. Fast forward to today, and our ability to identify congenital gene variations has surpassed the ability to treat. Thus, the definition of benefits for the population has evolved to recognize that having a conclusive diagnosis can end a barrage of diagnostic testing, and that this itself is a benefit. In this way, ending the diagnostic odyssey has become a valid reason to implement screening tests, although this goes beyond the traditional guidelines developed by Wilson and Youngner in 1968. In this context, testing for BRCA genes or for Lynch syndrome gene variants in confirmed colorectal cancer patients has been implemented. It is important to note that the identification of these genes is not for the cancer patient themselves, but for the family of the patient, as there is a 60 to 70% lifetime chance of developing colorectal or endometrial cancer in case of the Lynch syndrome genes. Without public health guidelines, there are challenges to drawing the line of what tests should be recommended for all people in a population, where healthy individuals are screened to find the proverbial needle in a haystack of a genetic carrier. Beyond identification of deleterious gene variants, public health can provide guidance on how to implement genetic information into existing programs. This fosters a growth attitude in increasing the likelihood professionals will modify their existing routines to incorporate genetic and genomic data. One chronic disease management program in Michigan is presented as a case study where social and behavioral principles were employed to encourage adoption of new guidelines regarding tumor screening. By focusing on evidence-based public health, the researchers identified successful methods for encouraging stakeholders to adapt to the new guidelines. There are also harms that public health can help identify so as to mitigate risks. Quaternary prevention is described as the reduction of over-medicalization of vulnerable populations to reduce all kinds of harm associated with too much intervention. Social and ethical fields of public health can help policymakers as private and public enterprises collect data related to genetics and genomics. Massive databases are required to organize all variations of genetic anomalies, and these anomalies are classified as variants of unknown significance, and genotype-phenotype associations and correlations are required to elucidate the best course of action when they are identified. Questions about who should have access to these databases, who maintains them, and who's responsible for the financial resources that it takes to accomplish all of this with the databases are unresolved questions. Secondary testing, where private companies desire access to the databases and to genetic data that has been accumulated from, say, the blood spot collected from all newborns in the country, raises questions related to patient autonomy and informed consent. Cost of widespread testing bears a significant implication for equity, and ensuring that low socioeconomic communities have access to testing and counseling is another significant hurdle to widespread adoption of genomic testing. Currently, whole exome or whole genome sequencing costs $500 to $600 and only a day's worth of wait time. This is a far cry compared to the Human Genome Project in 2003 that took over 15 years and hundreds of millions of dollars. Current recommendations based on CDC guidelines support the surveillance of genetic variations, even some that are without evidence-based interventions. Tension from companies that develop the tests are encouraging adoption, while public health professionals provide the pushback, asking tough questions about whose interest is best served by these new tests. Thus, public health stands as the guardian for practical and acceptable use of genomic data to ensure that improving health outcomes at the population level are the first and foremost concern. The consensus seems to be that genomic and genetic testing has a useful place in medicine. However, it hasn't grown to the stature where it's going to replace our standard diagnostic tests. Guidelines are recommending the implementation of these tests as screening concurrently with other methods of screening while the body of data accumulates showing evidence for the clinical and diagnostic utility. In summary, my research demonstrates a need for significant involvement of public health professionals in developing guidelines, assessing clinical and diagnostic utility, and observing ethical and legal issues that could cloud adoption of new technologies like genomic sequencing. I'm excited to join the public health workforce to promote great health outcomes for my community and beyond. Thank you very much for listening to my presentation of my research, and have a great evening.